This is Dr. Timothy Collins from the Duke University Headache Division, part of the Department of Neurology at Duke University. This is the first part of our CME course on headaches and head pain, primarily directed at primary care. We're going to begin with Section 1, which will be a discussion of several types of idiopathic headache. Section 2 will be a discussion of testing that might be done in the setting of a headache patient, and Section 3 will be on treatment options for some of the more common headache disorders. So we're going to talk about migraine headaches, tension headaches, cluster headaches, and trigeminal neuralgia. As an overview, migraine is very common. It's present in approximately 18% of women and 6% of men. Tension headache is actually much more common in the general population based on survey data, but because of a variety of reasons we'll discuss later, patients rarely present for care with tension headache. Cluster headache is estimated to be about 15 per 100,000 men and about 5 per 100,000 women. Trigeminal neuralgia is generally less than 10 per 100,000 in the general population. Obtaining a history is critical in evaluating headache patients, as we have no real diagnostic test for headaches. Important features that we want to understand in evaluating a headache patient are the frequency and severity of their headache or the pain in their head, as well as the quality and location of their headache, whether or not this is unilateral or bilateral head pain, whether or not the pain is throbbing and pounding or stabbing, burning, dull, electric, or shooting. All of these features are usually described by the patient when asked about the features of their headache. We also want to ask about associated symptoms, such as more severe pain or worsening with movement or activity, such as going up and down stairs or exercise, nausea or vomiting, sensitivity to lights and sounds, which medically are often described as photophobia or phonophobia, and any visual changes that patients may have, like blurred vision, which is fairly common but not particularly serious, or a typical migraine aura. In order to diagnose a migraine, we need several features present. Migraines in general have to last longer than 4 hours and may last up to several days. Of the following symptoms, patients need to have at least 2 in order to be meeting criteria for migraine diagnosis. They need to describe a moderate to severe pain, or unilateral pain, or throbbing pain, or pain that is worsened with activity, such as walking or going up and down stairs. Of these 4 symptoms, patients only need to have 2 to meet migraine diagnostic criteria. In addition, patients with migraine need to have 1 of the following symptoms: nausea or vomiting, photophobia or phonophobia. So at a minimum, patients need to have 3 of the symptoms described above, but may have additional symptoms such as sensitivity to odors that we call osmophobia, or a typical migraine aura. Migraine visual aura is present in about 1/3 of the patients that have migraine, and the trigger for the migraine aura is not clear. Migraine aura's underlying cause is spreading cortical depression, which may in fact trigger a migraine headache in patients. A migraine visual aura is a fully reversible visual phenomenon that gradually spreads and becomes larger and then fades out on the periphery of their vision. It's normally composed of both positive and negative visual phenomenon. Moving on, sinus headache is a frequent diagnosis that we see in the headache clinic. It's very popular with patients to describe their headaches as a sinus pain. Unfortunately, sinus headache may not actually exist. There have been a number of studies over the last 10 years that have demonstrated that the majority of patients who claim the diagnosis of sinus headache in fact meet criteria for migraine. So if you're caring for a patient who repeatedly presents for care for sinus headache, they may actually respond better to migraine medications than decongestants. As I mentioned earlier, tension headache is relatively common in the general population, but does not often present for care in the clinic. Tension headache is a constant or continuous dull, non-throbbing headache that is not severe. It's bilateral, usually frontal or occipital, but may be global. There is no nausea, vomiting, photophobia, or phonophobia with tension headaches, and tension headaches are not made worse by the patient's usual activity. So in general, patients have significantly less disability with tension headaches and rarely present for care with tension headaches. On the other hand, cluster headaches, while extremely rare, are significantly disabling. Cluster headaches are much more common in men, with a male to female ratio ranging from 7 to 11 to 1 based on which survey has been published. Cluster headaches last less than 3 hours, generally start abruptly, reach a peak in severity within about 15 minutes. The headache is a unilateral pain around the eye or periorbital pain that never changes sides. The pain is severe, stabbing, and incapacitating, and patients typically have a headache for 60 to 180 minutes, and then their headache goes away and they're completely pain-free until they have a second headache. Patients typically have more than one headache a day, and their headaches are often time-locked, meaning occurring at the exact same time every day, or occur during sleep at the same time of night and wake the patient up. Cluster headache is one of the trigeminal autonomic cephalgias and has very prominent symptoms of abnormal autonomic discharge connected with the headaches. Patients typically have tearing or conjunctival injection around the eye that is affected with the pain. They often have rhinorrhea with a clear discharge, and you may even see ptosis similar to what you might encounter with a Horner syndrome. Skin color changes and sweating are reported as well with cluster headaches, but these are relatively uncommon. Trigeminal neuralgia is another rare headache disorder that is seen occasionally in primary care clinics. This typically affects older adults, and the average age of onset is approximately 50 years old. This normally begins as a severe shooting electrical stabbing pain in the face that comes on abruptly and lasts for 3 to 5 minutes at a time. The pain is overwhelmingly severe, occurs in multiple episodes per day, and is often triggered by talking, eating, brushing the teeth, wind on the face, or makeup and shaving. The pain is described as overwhelmingly severe by patients. Trigeminal neuralgia pain is almost always unilateral and typically occurs in the third division, which is the lower part of the face along the jaw, or the second and third division, affecting the area under the eye as well as the jaw. Trigeminal neuralgia is also unusual for other primary headache disorders, as there are a number of secondary causes of trigeminal neuralgia that are seen almost as frequently as primary trigeminal neuralgia. Multiple sclerosis, acoustic neuromas, posterior fossa masses, including meningioma or metastatic disease, can all cause trigeminal neuralgia. And this ends part 1 of our 3-part series.